I think unquestionably, probably the most exciting advance has been the remarkable results that are being observed with the BCL2 inhibitor Venetoclax. We understand from the company website that the VRE-A study, a randomized study comparing an azacitidine venetoclax combination with azacitidine in de novo unfit AML is positive. Those data are going to be very important to analyze as they come through. But I think that's perhaps no surprise given the excellent phase 2 data that has been published. So I think the question now moves to how you optimally use venetoclax in older patients, and there's a question of whether it can be combined with targeted therapeutic strategies, potentially the use of FLT3 inhibitors for that population, and then also interest in whether venetoclax can be combined with other targeted agents such as IDH1 or IDH2 inhibitors. And I think the other really interesting question is the impact of venetoclax on treatment of fit patients. There are a couple of areas I think are particularly worth watching. First is that the outcomes for NPM1 positive older patients treated with venetoclax and Ara-C or azacitidine are remarkably good. Very high CR rate, and these CRs seem to be durable. So that raises a question as to, in fit patients, perhaps slightly older patients who'd otherwise get chemotherapy and whom nonetheless the toxicity of chemotherapy is significant, whether one would be able to safely move to a venetoclax-based regimen with all the attendant benefits. That proposition is going to be addressed in an NCRI AML working party study called Victor, led by my colleague Richard Dillon, King's. And then I think the other interesting question is whether by combining venetoclax with intensive chemotherapy, whether you can improve the outcome of 3+7 induction chemotherapy, or building on some of the work from MD Anderson, whether giving FLAG-based regimens with venetoclax is a more effective salvage regimen. Certainly they've got some quite dramatic data. And then finally, I think the use of venetoclax post-transplant as a maintenance agent is an area of great interest, and that's being addressed in the VRE-T study where AZA and VEN are going to be given post-transplant. So that's really where I would suggest there's been the most significant improvement, most significant advance. There's also some interesting data with Cusatuzumab, anti-CD70 antibody, which looks very promising, small numbers of patients, and also some nice data using the anti-CD47 antibody, Magrolimab, in conjunction with AZA. So I think a number of these targeted therapeutic strategies are looking very promising, and so we're now needing to move as swiftly as possible to randomized studies which embed genomics so we can identify the benefit of these novel interventions and also identify the subgroups. And pivotal in all these studies, of course, is understanding the impact of these novel agents on MRD.